Christina. This is Al. He's been telling me for a decade that he's practically a doctor. So we decided to test that theory. Seriously, though? He's not a doctor. He's an idiot. And honestly, medicine is constantly changing, so I'm probably wrong too. The point is, this is not medical advice.
Help. So, what have you got for me?
I have a 3-year-old black male patient, 14 kilos, came in with difficulty breathing, has some seasonal allergies, no other allergies are known, has past medical history of RSV at 2 months old, and eczema. Heart rate is 125, sinus rhythm, blood pressure 105/62, respiratory rate of 45, Tmax of 98.9, and an O2 sat of 92%. He's awake, alert. He's giving one-word answers to questions, so he is still speaking. Pupils are 3 and brisk. Pulses are 2+. Heart tones are normal. He's got a brisk cap refill. He is sitting in a tripod position. We hear an expiratory wheeze, some intercostal retractions, nasal flaring. He's got some clear nasal secretions.
Okay.
He's had a poor appetite for the last few days. No other complaints from mom from a GIGU standpoint. Musculoskeletal, his skin's a little moist. There's a small rash noted on his right arm. Nothing from an infectious disease standpoint. Home meds, mom gave him some Claritin. She gets it as needed. He's been getting it the last 3 days. No access as of yet. We haven't done any labs or chest x-rays or anything yet.
Okay, what was the temperature?
98.9.
Okay, so no fever, bunch of skin stuff. How old? I'm sorry, you said 3? 3 years old, one-word answers. Okay. Not a pediatrician, I'm a doctor. I know doctors are also pediatricians.
Yep.
I'm not a pediatrician. I feel more tense right now, and that's fine.
Kids usually make people feel more tense.
Yeah, absolutely. And this is very real medicine that I'm practicing here. So
you should be worried.
So I should be worried.
Patients should be worried.
I should get a consult. That's what I should do. But I don't have any of those. I don't have any.
Okay.
I don't want to brag or anything, but I don't have a whole lot of colleagues.
That tracks.
Yeah. Okay, so skin. We got a bunch of skin stuff. Haven't done any tests on anything yet. What would you say about the breathing?
We're hearing an expiratory wheeze. There's some intercostal retractions, nasal flaring, and he's sitting in a tripod position.
Okay, so he's having difficulty breathing, and he's got a bunch of skin stuff. That sounds like allergies, but he's on Claritin?
Yes, he took Claritin at home this morning.
Okay, and he's been on that for 3 days, you said?
Yes.
Okay, so let's try okay, we're going to try steroid that you can give to 3-year-olds.
Okay. Do you want me to put in an IV so that we can give that IV, or do you want to give it by mouth?
The blood oxygen was 92%.
Yes.
That's a little low. Let's go safe, and let's go better safe than sorry and try it as an IV.
Okay, so I'll put in an IV.
And then, do we think is he going to let us give him an IV? That might be a problem with a 3-year-old.
I mean, the 3-year-old's not going to be like, here you go.
Yeah, but y'all
right
can handle
there,
it. The nurses are the problem in this medical facility. So there's a problem here. It's not on that half of the room. So let's try the IV. Let's also, it's steroids. Let's do a chest X-ray.
Okay.
Let's see if we've got stuff in the lungs, and then let's also let's try an ointment on the skin that is some kind of allergenic thing that has a different ingredient than Claritin.
Do you want like a hydrocortisone cream?
Yes, that's what yes. A hydrocortisone cream. Very good. You're really coming along well. I'm proud of how much you've learned.
I've learned from the best.
Yeah. Oh, good. Thank God. Can you call him? Or her. I'm not trying to do a gender thing, you know. Then, yeah, let's do that, and then chest X-ray, and yes.
Chest X-ray, hydrocortisone cream for the rash, put in an IV so we can do some IV steroids.
Yes.
Okay.
Let's do that.
Do you want any other labs or anything?
Let's get a blood panel?
Just everything. When I start the IV, I'll send all the labs.
Yes, all of your standard stuff. Let's check those things.
Okay. Sounds good. So labs came back.
Mm-hmm.
Unremarkable. Nothing fancy.
Oh, God.
WBC is a little on the high side. Not terribly.
Okay.
But labs look normal. Respiratory therapist also got a blood gas. Your pH was 7.32. CO2 was 58. Oxygen 64. Bicarb 22. Base excess +2. And a stat of 86.
Mm-hmm.
Would you like us to put him on some oxygen?
Mm-hmm.
Sure.
Yeah.
How do you want to get that?
Orally. As opposed to pill form.
Well, I can do like a mask,
Let's
or
just
I
do a
can put a
mask.
nasal cannula on him.
Let's do the maths.
Okay.
Because his blood oxygen is 92%, so it's not so low that I'm panicking. So let's do the mask. And
All right. Let's see how he does.
next patient.
You killed him. I'm
God,
sorry.
Look, I know, folks, that this is all fake. I get that. And I've been fine with it. It's funny. I can laugh at the jokes. Not a medical professional. I know that might surprise some of our listeners.
It
watchers.
should not surprise any of you. We say that at the beginning. He's
The shirt's a joke. It's a joke. It's not actually. But the second I heard that this was a little kid, I'm like, oh God.
Sorry.
Yeah, that's all right. That's all right. So I killed him.
You did. And this was
I tried, dude. I don't
you
even
did.
tell.
You did.
I was trying.
And there were some things that you did very well. Steroids are a great medication to give this patient.
Nice.
However, he is an asthmatic with a severe exacerbation at this point. So putting an IV in him, especially.
I should have recognized that he was asthmatic.
So tripod positioning is sitting forward like this.
Right.
Speaking in one-word answers, even though he's 3, he should say words back to back. You know, even if he's delayed verbal, like he should be able to babble.
Like I'm not saying that I would have saved this patient, but I should have caught that he was asthmatic. That I should have.
I was surprised. You said allergies, and I was like, you're almost there. And then you didn't get to the asthma piece. So the expiratory piece, clear indicator for asthma.
Yeah.
Intercostal retractions and nasal flaring, so that's the being able to see ribs as he's breathing in, means he's pulling really hard, nasal flaring, his nose opens up real big.
He's trying to get more air in his body.
He's pulling, and he's working hard to breathe. If we come at this kid with a needle, like no 3-year-old's gonna be like, here you go, it's right here.
Yeah.
But if we come at this kid with a needle, he's going to freak out, which will make his breathing worse, which will then exacerbate his asthma.
God, I genuinely feel guilty about this one. All right.
So chest X-ray first. That's going to show you hyperinflation of the lungs.
Did I do that?
You said chest X-ray after IV steroids and IV labs.
Oh.
So if we tried to do it in that order, that would not have. So definitely, the chest X-ray is something you needed to get. That should allow them to stay relatively calm. You can do that at the bedside. Parents can be there, so that's okay. This kid, you want to allow him to sit with the parents. Whatever it takes to calm him down and keep him calm is what you want. That's another thing with the oxygen. He probably needs oxygen because his airways are very swollen and narrowed. And with asthmatics, the problem isn't getting air in, it's getting air out. So that's why his O2 stats are 92. They're not terrible.
Right.
But at some point, you can keep getting air in. If you're not getting anything out, you're not going to get anything in either. So giving oxygen is a good thing. But the reason I asked how you would want to do that, a mask is actually a great choice. Because putting nasal prongs in their nose is only going to agitate him further.
Right,
so you can actually give a mask like on blow-by and like put the mask up really high and allow the parents to hold it near their face instead of putting it on their face. Just kind of give them this blow-by oxygen. That helps give them some extra oxygen without making him more agitated.
Gotcha. So with the steroids, they're safe if I hadn't tried to shove a needle in his arm?
The problem is steroids take a really long time to work. So you can do inhaled steroids, and you will need that, like breathing treatments, like Albuterol. In fact, that's a common standard treatment for controlling asthma. Asthma inhalers.
Right.
Albuterol is really what he needs. And for this patient in this type of
And albuterol is not a steroid?
Albuterol is not a steroid.
Got it. Okay.
I forget what class of drugs it is.
Well, it's
But
not like I
it's-
would understand it anyway. But
But
that's
it is a very rapid it's a rescue med for asthma. And so it's rapid acting, it causes dilation of the bronchioles, and it works very well. With this patient, you would probably need a continuous albuterol treatment
got
in the
it.
ICU. You definitely want to try to keep the sats above 90%. You can give ipratropium with the albuterol. That can help. IV steroids eventually. Once you can get him calm in a controlled setting, get that IV in, then IV steroids are going to be necessary. But let's get his breathing control first.
So should I have done? So beautiful. I shouldn't have been bothered with steroids yet.
Nope.
Okay, IV or otherwise.
Albuterol first.
Albuterol to get everything.
Yeah.
Regulated and get him down, and then
Yeah.
okay.
And then you can do something like nasal Versed
Mhm.
that can help calm him to get the IV in.
Got it.
Because you are going to need that eventually. But you want to try to wait till you have his breathing controlled. This is also a patient you're going to want to avoid intubating, putting that breathing tube in. A lot of people think, oh, good, now we have a stable airway, we can just get it in. The problem is it's not your upper airway that's the problem, it's your lower airways. That breathing tube does not help keep the lower airways open.
Gotcha.
And when you put them on positive pressure ventilation, that actually impedes flow coming out. And since your problem is air coming out in your asthmatic patient, shoving more air in does not help. That causes more barotrauma.
So why when the lungs are when the ribs are showing because he's trying to breathe in, it's because he can't get the existing air out. They're already full, so he can't get the. Got it.
So that's why you get that expiratory wheeze. You
Gotcha.
get the wheeze on the air coming out.
Okay.
So now I will not say you never intubate an asthmatic patient. If you can't get their breathing controlled any other way, you may have to intubate them. You would want to use ketamine as an RSI instead of some of the other meds because some of your other RSI meds can trigger that bronchospasm response. Ketamine will not. You're also going to want a longer expiratory time on your ventilator and a shorter inspiratory time to give more time for that air to come out. Really low tidal volumes, like 6 to 8 mLs per kilo. And you're probably going to have a high peak. They may require what's called manual decompression when they're on the ventilator.
Somebody's got to push it down.
So you disconnect them from the vent, squeeze the chest, and try to shove all that air out,
Good God.
and then put them back on the ventilator.
Like every
So-
breath?
No. Just
Okay.
like every 4 hours. Or, if you feel like you're not getting good volumes on your vent's dinging high pressures, then you may have
It's
to.
gonna like break ribs and shit.
I mean, it doesn't in pediatric patients. And this doesn't really happen a lot in adults.
Got it. Okay.
Fortunately. So long-term, some other IV meds you might need to use, magnesium sulfate and epinephrine are really good options for like IV infusions to help reduce this response. Long-term management, a lot of family education. They need to be on an asthma action plan that tells them, here's how you know you're in a green level and a good level that your asthma is controlled. Asthma is not something we fix and they go home and it's done. It's something they have to keep controlled or they're going to be back every 6 months with another exacerbation. And it can be deadly for these pediatric patients. So
Gotcha.
asthma action plan, long-term plan.
Okay.
They don't die in the hospital.
Well, as always, folks, please do not take this as medical advice. You can check the notes and such that we got in the comments. If we missed something, let us know and let everybody else know education and all that good stuff. Is that it? Missing?
That's it. Let's see how the other one fared.
Not going to be good. Until next time, thanks, everybody.
Thanks.